Hello and welcome, everyone. My name is Jenny Peck. I work at Amref USA. I know many of you here, and for those that I don't know, I'm so glad to have you here with us. We are joined from Amref UK and Amref Canada together on this call, along with our wonderful colleagues in Amref Kenya and Amref Uganda to talk about their work. Today we have Anne Gitimu. Anne, do you want to give everyone a wave? Yep, Anne is the Director of Reproductive, Maternal, Newborn Child, Adolescent Health and Nutrition Programs working in Kenya. We also have Dr. Kapsandui, the Program Manager for Maternal and Child Health and Nutrition at Amref Uganda. Tony, can you give a wave? Wonderful. And then we have Morine Moseka, who is a midwife at Rhino Camp Refugee Settlement in Uganda as well, working for Amref Uganda. Morine, can you give a wave? Wonderful. And then today's moderator will be Bob Kelty, the CEO of Amref USA. Bob, I hand it over to you. Welcome.
And I give a wave. Well, thank you everyone for joining. Really appreciate it. And I think we have an incredible panel today that will have a lot of different perspectives. I'm kind of from a leadership place, from Maureen, who's in the field as a midwife doing incredible work. So I think it's a really good mix of folks. I think you'll really have a great understanding of the work that's going on in both Uganda and Kenya. So I think I'll just start out with putting a little context about Amref, how things have changed and not changed. Amref's been around since 1957. We started in Kenya, Uganda, and Tanzania, and the organization has grown dramatically. We now work in 35 countries, but still our core work is maternal and child health. And how we've gone about it, I think in the beginning, we were always focused on, and this hasn't changed, but building the capacity and training and mostly in-service training of midwives, community health workers, and nurses has kind of been our forte, what we focused on. But as the years gone by, and usually it was in-service training, but now we actually launched a university. We're actually giving degrees in community health work, midwives, nurses. So this understanding, because there's such a gap of qualified medical professionals or health professionals, and more than ever we feel like we need to invest in that. And so it is one of our primary focuses, is building capacity. As always, I worked with Amref in the mid-90s in Kenya and Somalia and South Sudan. And what I could say is that core of building human capacity hasn't changed, and it's something that it's so important, because I think investing in people is the best way to strengthen health systems. I think one of our big changes is how we look at maternal and child health. I think in all healthcare, we look at it, I think so much of healthcare really coming from donors, and it's not how we do it in other countries, but it's very siloed. It's very much, okay, we're going to have a nutrition program. We're going to have a maternal and child health program. We're going to have infectious disease. And that's not what communities think. They think about in a horizontal. It's like, these are the services we need, and they need primary health care. And so what we really have been pushing, and really one of our changes is, universal health access, but having all these programs in one space where they can do it, where can they get all the services, instead of going to different programs to do different things. So I think that's one of our agendas. So that is how we're looking at maternal and child health in a different way. And Tony and Maureen will kind of talk about it really from the field. They're the experts. So I think you've heard enough from me. And let's get started. I will start with Anne, because she looks at the big picture. She oversees all the maternal and child health programs in Kenya, really, but also has perspective on all the work we're doing, in the 35 countries. So, Anne, if you could just give an overview of the work you're doing, how you look at the other projects or other programs in Amref, and how we think about maternal and child health.
Thank you, Bob, and thank you so much for this opportunity to share on a subject that I'm deeply passionate about. And just a bit of background about myself. I come from rural Kenya. And just like any other child growing up, I wished for better housing, better healthcare, better education. And as I grew up, I really resonated with this whole issue of health, starting from an early age. When I was about maybe 10 years in grade 4, we had this wonderful English teacher. And one day she didn't come to our class. And when we asked around, like, why don't we have our English teacher anymore? We're told that her daughter died while giving birth. For me, at an early age, what I knew is that people die from road accidents, they die from illnesses, but I had never heard of this angle of people dying, especially women, from childbirth. And it stuck with me, but life moved on. I went to college and joined Amref. Went on, I came to the realization that women actually die in childbirth. And Amref has really shaped the way I look at issues to do with maternal, newborn, and child health. Our work focuses on the moms, be it nomadic pastoralists, people who move from place to place in search of pasture for their animals, people who live in informal settlements, refugees and host communities, women who live with disabilities, and rural women, just like, where I come from, the women that live in that kind of environment where access to healthcare is a real challenge. And these are the types of populations we reach, and we have defined them as last mile. And they're the ones that we work very in hand with government, strengthening the public sector to ensure that they're reached with services, as well as just ensuring that we are able to bring on board the private sector. So we reach a diverse group of women and children to ensure that they have safe deliveries, that they have a joyous pregnancy, and that their children are able to see their fifth birthday with a set of high impact interventions. And we hope that we can discuss them even in this call today. Thank you.
I'd like to introduce, we recently visited the Amref US team that visited Arua, Uganda, which is on the is northern Uganda, right on the South Sudanese border. And we had the pleasure of Dr. Tonny showing us around the projects. I think we spent two full days there, and really just incredible work that was going on. So I would love, Tonny, if you could tell us a little bit about yourself and just kind of the work you're doing in Uganda regarding maternal and child health.
Well, a very good evening from Uganda. Greetings, everyone. I think as Anne was speaking and got the internet challenge, I was also praying this doesn't happen to me, because that's the reality of life where we live in. We live in this part of the world where some of the things may not be consistent. So I really hope I'll be audible. And so once again, it's a pleasure to be in this platform. Thank you, Bob and everyone, Amref USA. And thanks everyone for making time to come to listen to us. So my name is Dr. Tonny Kapsandui, and I'm a trained medical doctor, a public health leader, and a public health specialist at that by training. I have 18 years experience working in the health service delivery sector, and also programming in reproductive, maternal, child, adolescent, and newborn health. I have also done work in HIV/AIDS, and then in nutrition, in policy, and advocacy. And there is great need for advocacy in this part of the world, because we still have a lot to do to ensure that mothers and the children are safe and healthy. So since the year 2005, I have worked with the local government, that's the Ministry of Health, Uganda, where I served as a medical officer, a general practitioner, and proceeded to work with national and international non-government organizations. But for now, I am currently working as the program manager for reproductive, maternal, newborn, child, and adolescent health and nutrition at Amref Health Africa in Uganda. And this program in Uganda is spread across all the regions. We have about 15 regions, sub-regions in this country. But in terms of districts, we serve in 63 districts out of 136. And on an annual basis, we reach out to about 2 million women, girls, young people. It's a range of maternal child health services and also sexual and reproductive health information services. So it's a pleasure again to talk to you from Uganda. And as I may realize, I think some of you may have not had the opportunity to be in this part of the world. So I'll give you a quick context about this country, great country in East Africa. So it's a landlocked country in Eastern Africa with a population of just over 46.2 million people. And the majority are females, slightly more than the males, that is 51%. And we are a very young population in this country. We have 78% of people being below 30 years of age. And I'm taking time to speak to you about this because some of these things impact what the burden of maternal and child health we experience in this country is. So 78% are below 30 years of age. And the teenagers, that's 13 to 19 years, make 11.7% of the population. And before I leave that one, let me chip in this. For these teenagers, out of every 4, 1 has ever gotten pregnant before their 19th birthday. And that's a big issue in itself. If a teenager gets pregnant, where the health system is weak and needs a lot of strengthening. So 42% of all the pregnancies among the adolescents in Uganda are unintended. In other words, not planned for. They just show up, an adolescent. Now, when you talk about adolescent, that's the age bracket of 10 to 19 years. You can imagine we have those as young as 11, 12, actually getting pregnant lately in this country. So it's a big challenge. And 66% of the new HIV infections, which is a big issue in this country, HIV, are found among the adolescent girls. Imagine 66%. And then 60% of adolescents have experienced some form of violence, be it physical, emotional, and or sexual violence. Now, most of these people struggle when there is need to access health services because 1, they may lack the information, 2, they are poor and not empowered to access, versus even the long distances they have to traverse to reach the health service delivery points, and then just generally poor quality of services once they get to these health services. They may not be really satisfied with what they access. So that's it really about Uganda. But before I leave it entirely, Uganda is unique in a sense that we are known to host a big refugee population in this country. As of July this year, we are hosting 1.578 million people, refugees, most of them coming from Southern Sudan. Then the next coming from the Democratic Republic of Congo. And the majority of them, again, are the vulnerable group, women and the children. We have a few elderly ones and the youth. Youth are 15%, but 82% women and children. Now, when you have this influx of refugees coming in to, especially the region that we are talking about, which is West Nile, I'll tell you more about that, where Amref's work is, where the Amref USA team visited recently. Now, when you have these people coming in, they constrain, they begin to stress an already weak health system. And that explains the relevance of really much investment in such regions. So the majority, like I said, are from South Sudan, then others are from the Democratic Republic of Congo. We have in some districts, I'll cite an example, a district called Adjumani in West Nile, where we have a ratio of refugee to the host population as 9 to 1, you can imagine. Like they're almost balancing, like the number of refugees settled in this area is the same number almost of the host population. So you can imagine the burden that they bring. So really, to put it more into perspective, the maternal child health situation in Uganda, as of September from January this year to September, we have recorded loss or death of at least 700 mothers, either due to pregnancy or delivery or childbirth process complications. That's huge, I'm sure, compared to the USA and other places. And just in 1 month alone, in September, we lost 362 babies, either those just about to be born or during delivery or just shortly after delivery. That's what we call perinatal death. Imagine just 1 month alone, 362 perinatal deaths. So that's really the picture we are talking about in Uganda. And that's where Amref becomes really relevant, the interventions that we bring to address these issues of maternal and child health in Uganda. Now, the most affected region is the region that the Amref USA team visited recently. That is West Nile. This is where the indicators are really bad. And during their visit, we were able to show them the work that we do in the region, including one of my favorites. That's the obstetric fistula prevention and repair project. So, friends, if you let me proceed, I'll share with you an experience that makes me say this is my favorite project that I implement in Amref, among the many others that we do. One of my earliest touching experiences as a young medical doctor working in a rural hospital in Uganda, particularly Eastern Uganda, was when I came across this middle-aged woman who walked in to this hospital where I was working in. And on that day, I was serving at the outpatients clinic. And so when this lady walked in as the next client I was to see as the doctor attending to them, I was greeted by a very strong smell of urine. And that's unusual, as you may imagine, very unusual. So, and it was really strong. So, but interestingly, that's not what brought her to the clinic. She came with a fever, complaint of a fever and a headache, if I recall well. And but I had to find out what this strong smell was about. And as I took the deeper history, medical history, she actually informed me that she suffered a complication after a very difficult process of labor and childbirth. Unfortunately, that child did not survive, and that was about 15 years plus. It took a number of years that she had lived with this condition. So, ladies and gentlemen, obstetric fistula is a complication that arises from a difficult labor process, a difficult childbirth or delivery process. And this is mainly because maybe there is no skilled birth attendant to attend to this woman. Maybe this woman is caught up with the labor process and at home cannot reach the health facility, and many other factors, including the teenagers who get pregnant. Their bodies are not really prepared to have a safe and adequate delivery. So that is the complication called obstetric fistula, where a hole develops between the urinary bladder and sorry to say this, but we have to say it, and the vagina. So the urine begins to leak from the urinary bladder uncontrollably, and it comes out. So you can imagine the debilitating condition that these women go through. And Amref is doing this work in West Nile, trying to restore the dignity of these women. And we look out for them in outreaches, community mobilization, and then screen and identify them, take them to repair centers that our projects have prepared, do the repairs successfully, and then reintegrate them back to community. And the point of reintegration is very important because when these women are living with this condition, they become social outcasts. They don't live with the family. Most times their husbands have left them, and they can't even go to the market and sell their farm produce because the smell of urine that keeps leaking constantly is strong. So they become discriminated and stigmatized. So really that's the challenge. And it's a big challenge in this country because we are talking about currently a backlog, an estimate of about 100,000 fistula cases still out there, unattended to, unaddressed, and repaired. And you can imagine that number of women struggling in these kinds of situations. So, friends, that's my story. I'll continue to tell you how it transformed my life. I used to dream of being a neurosurgeon. When I finished medical school as a general practitioner, I was certified to practice, and my dream was to be a neurosurgeon. And when I worked in this hospital, and specifically from that day, I began to imagine that, look, this condition that this woman is suffering could have actually been prevented if she had access, maybe antenatal care, quality antenatal care services, if she had delivered from the health facility and on time, and maybe if she had been attended to by a qualified health worker, such as a midwife. And so I began to think that and many other cases I saw that there's a lot we could do actually down in the community. And I dedicated that my life that I would actually transition, drop my dream of being a neurosurgeon and move to the community and work. Now, before I moved to that hospital, in my residency as an intern, I'd worked in another hospital, which was a regional referral hospital. Few hours, maybe 2 hours drive from where I was working. And they used to do what we call obstetric fistula camps. I had no idea who was funding these camps, but I used to observe them happen. Here I was with a case of fistula, and I interested this lady to go there. Indeed, she went, and she was successfully repaired. Unfortunately, I lost contact shortly after that. Those days, the phones were not common. That was 2006. And but she gave me feedback, came back, and she had been repaired successfully. Now, 10 years later, I get a job with Amref Africa in Uganda as a program manager, RMNCAH program. And guess what? That's when I find out that these camps that I used to hear about were actually by Amref Africa in Uganda. So we've been in this business for a very long time. I can talk about in our records slightly more than 2,000 obstetric fistula cases repaired and more than 2,000 cases of other birth injuries due to complications that have also been repaired. So it's really satisfying, fulfilling to be a part of this work that we do because we see a restoration of dignity to these women. We bring back the smiles. The team that came from Amref USA, I'm sure you saw the smiles on those that have been successfully repaired in West Nile when we made the visit there. So really, this is what we are talking about, the reality on ground. And I have my heart full of joy and satisfaction that I'm doing the right thing. And I really want to thank you for listening to me. And really, when the time to make the call, you can guess what call I will make to you. Thank you. Over to you, Bob, for now.
Thank you, Tony. Especially thank you for sharing your personal stories. I think I've heard them before, but even hearing them again, it's just so inspiring and moving. The whole U.S. team got to meet Dr. Tony, and he showed us around the different projects. But one of the things that really moved me most, and I talked a little bit about the integrative services, we went to an outreach camp. And in the morning, it was just a field. And the team got there very early, built the camp. There were malaria testing services, vaccines, maternal and child health programs. There were so many different programs there. And I think there were probably about 600 people who came to the camp. And so one of the challenges when you're dealing with that many folks is how do you keep them there? Because the services are slow. And one of the things that it just was so amazing to see was how the team, the community health workers kept them. They put on messaging shows that were dance. They got everyone dancing. Then they did plays to talk about the importance of vaccines, songs, and really just kept engaging the people, the children, because some folks because the services are so limited, have to wait quite a bit. And it was just amazing the energy that they kept there. And I think at one point, we tested 300 kids for malaria, and about 150 or 60 had malaria. We were able to treat them. And those numbers, because it's a very high malaria area, and it's a high prevalence area, but just the work, the commitment, 10 hours there, just working plus setup. It was just really inspiring to see. So, thank you, Dr. Tony, Lillian, the whole Uganda team for, taking us out and seeing the work. We actually have a video that will send you a follow-up where you can see actually the work they did, how the clinics or how the outreach was set up. So we'll be sharing that. Now I want to introduce everyone to Morine. I was able to meet her, and the whole US team was able to meet her. We're at a clinic, formal clinic at the outside of Rhino Refugee Camp, and where she works. What amazes me, and Dr. Tonny touched upon, is the opening, how welcoming that the Uganda people, Uganda government is actually from refugees from South Sudan. And I think I compare it to how the US handles it, and it just was really stark on how welcoming we were. Morine, would you mind telling me a little bit about yourself, why you do this, and kind of what your day-to-day workday looks like, and kind of the patients you're seeing, where they come from too, would be really helpful. So the floor is yours.
Good evening from Uganda. My name is Morine Moseka. I'm 25 years old. I'm a Ugandan. I'm an enrolled, caring, competent midwife. Before I move far, I really want to tell you people what motivated me to become a midwife. When I was 7 years old, I lived with my mom in a remote village where I kept watching mothers pregnant women move long distances to seek healthcare services. I watched so many pregnant women deliver in hands of unskilled traditional birth attendants. Now, the most touching story happened when it happened to my own mom. After giving birth at home, she could not afford transport to go to the hospital. After giving birth, she started bleeding badly. I was really traumatized as a child. Luckily, my mom survived that by grace of God. From that time, I promised myself I'm going to become a health worker. I'm going to help mothers during pregnancy, when they're giving birth. I'm going to help their children out. But it was really hard because I come from a very poor family. My parents could not raise school fees for me. But I made that as a goal. I had to achieve it. I kept praying. I reached a level up to where I joined the midwifery school. The unfortunate part was I lost my dad, who could really provide for me. It was like a dream coming to an end. I was shattered. I signed for a dead year. I took to the principal of the school. She gave me hope. She told me, you know what, you can really go far. You're intelligent. You will become a good midwife in future. That thing gave me hope. She got me one sponsor who paid me in school. I completed my course. During my course, I kept practicing in different hospitals. After my course, I've helped so many mothers to overcome challenges of bleeding, dying from bleeding after death. I've helped so many pregnant women during their pregnancies. Now I stand here today as a proud midwife because it was really not an easy journey for me. Right now, I'm really so excited. I'm so happy. And I've had really experiences in midwifery field. I've worked in a government health center where I'm able to do antenatal care services and where I'm able to offer deliveries, not only deliveries, but safe deliveries to mothers to prevent complications and now prevent this bleeding after birth. During labor, I prevent it during labor. There are some things I know I do. So I've helped save 2 mothers from that. I don't know why God always brings this incidence of a woman bleeding after birth to me, but I think it's because of the promise I made. This happened when I was volunteering in Oli Health Center 4, There was a mother who was delivered by a different midwife. The midwife didn't really care well. Now, I was just a volunteer student. For me, always, I care about my patients. I move from ward to ward to check my patients. How are you doing? How are you feeling today? We are really friends. So I reached this mother. I said, hello. She could not respond. When this mother was in a pool of blood, unconscious, has lost a lot of blood, I said, God, you called me to serve. I know I'm a volunteer student, but I'm going to stand and save this mother from this. There are things I did. Of course, in that health center I could not, there are some services which we don't have. I did my best. I referred this mother to a regional referral hospital. The mother stayed there for 1 full month because she became anemic. She lost a lot of blood. I was really proud that the mother's life was saved. Now, I work with Amref Uganda in West Nile region, in Rhino Camp Refugee Settlement. It is really in a remote area where I now get opportunity to serve the refugees from South Sudan and from Congo as well. The particular name of the facility I serve is Ofua 6 Health Center 2. There we have population of 10,000 refugees. We offer different services to them, but we are only staff of 4, 1 clinic officer, 1 nurse, 1 midwife, that is Morine, 1 lab tech. These refugees really go through a lot of health challenges, malaria being the leading cause of death. They go through challenges of malnutrition, urinary tract infection, upper respiratory tract infections, even mental health illnesses. You know, they lost a lot of people from Sudan, they lost relatives because of limited supplies of food. We are now registering mental health cases, which really needs to be addressed. As a midwife, it's like my dream has come true. I now help these pregnant women during antenatal. I help educate them on danger signs of pregnancy. I prepare them for labor. I assess their nutritional assessment. I assess their nutritional status. I monitor their blood pressure, because high blood pressure is really a dangerous condition in pregnancy. As a midwife, it is also my role to screen for diseases like malaria. In my facility, every month, on average, I can get 40 mothers tested positive for malaria out of 180 mothers. Yet malaria is really dangerous during pregnancy. I screen for HIV and syphilis. My aim is to eliminate transmission of mother to child infections. I screen mothers early. The ones I get who are infected, I counsel them. I treat them. I make sure the mother and the baby are in good state. I really enjoy doing that. I feel my dream has come true. Every morning I wake up with that strong feeling that I'm going to serve a mother, I'm going to save someone's life. It gives me energy each and every day. I'm really that proud midwife, caring one. In addition to that, I do family planning services. I help these pregnant, I help the community, I help the mothers to have children by choice, not by force, not by chance. I offer family planning services to them. In addition to that, I also have youth-friendly services where I get chances to talk to young girls about dangers of teenage pregnancy, prevention of STIs. I tell them to study hard, to stay in school. My story motivates them a lot. At least I feel good. I also do immunization services where I immunize all the children under 5 against the vaccine preventable diseases Of course, prevention is better than cure. I immunize them against diseases like polio, tuberculosis, pneumonia, measles, yellow fever, hepatitis B. I immunize them. The ones who drop out because of some long distances, it is my duty to track them, to follow them up to community, to offer the services to them. I also protect young girls of 9 to 10 against cancer of the cervix by immunizing them with HPV vaccine. I really enjoy my work. I really feel good doing it. We offer outreach services where we take services outside the facility. Some people are old, they could not move to facility. We take services to the elderly, and that we take services outside in communities. We offer every service we could do at static there during outreach, including COVID-19 vaccination. And I really enjoy doing that. Amidst all this tremendous work, we have also challenges which really needs to be addressed. One challenge is my facility is a health center too. It does not conduct deliveries. But the next facility where a mother will give birth is 10 kilometers away from there. This has really increased home deliveries. Of course, a mother will tell you, I don't have transport to go there. Of course, we don't have ambulances. These mothers end up using their own transport. The ones who don't have transport, they will choose to deliver home. But for my facility to start conducting deliveries, it needs to be upgraded to a health center 3 setting. Yeah. But when our project started in Rhino Camp, the number of home deliveries were really high. But I tried my best. I didn't want what happened years ago to repeat itself. I didn't want mothers to be delivered by non-skilled midwives. I took it upon myself to start creating awareness about dangers of home delivery to mothers. I health educated them on signs of labor so that labor started, I don't need to stay home, I need to go to the health center. I took them through birth preparedness. Since there was no ambulance, there's nothing we could do, but still we needed to solve the problem. I'll prepare them for labor. I'll tell them, at least you start saving something little, at least if you can. Of course, you're going to carry the pregnancy for 9 months. You really need to save something little. When labor starts, you don't have to deliver home. It really worked. As I talk right now, my mothers are trying so hard. I do not have cases of home deliveries again. I'm really so happy for that. But I would wish it to be addressed if possible, because a mother traveling, can you imagine, is on labor, is feeling pain, and is using motorcycle to go 10 kilometers on a very bad road. I really feel bad, but at least I can help support them psychologically before their labor starts. That is really, really important. Another challenge we face in Rhino Camp Health Center, we really do not have source of light. That limits us from offering emergency services that come at night. And it limits me as a midwife from offering services like immunization daily, because these vaccines are brought from the same facility where mothers are delivered. It is 10 kilometers away. Yet these vaccines really need to be maintained under a cold chain. That is really, really a challenge that needs to be addressed so that we offer quality service, so that we're able to save lives even at night, because you really don't know when sickness comes, you really don't know when a condition changes. I also have challenge that we are staying very far from the community, from the health center too. We are renting with the refugees. though this has built good relationship between us, the health workers, and the refugees and the communities we serve, but I feel it will be better for us to have our own accommodation near the facility. With the light being available, we're able to offer services anytime the need arises. Anytime emergencies come, we're able to offer the services, if only we stay near the health facility.
Thank you, Morine. Thank you so much. I just can't emphasize the barrier travel is, and the clinic is on fairly high hill, and Morine pointed out to me in this beautiful vista that was very dense with trees in there, how far people had to go. So it's not 10 kilometers on an easy road, and it's such a giant barrier for safe maternal or safe childbirth. And you know, it's one of the challenges. I think there was a clinic a little closer, but just because of funding, they had to close down. But the work that Morine and the team there is doing with such limited resources, just amazing. I think everyone from her description understood that. So thank you again, Morine, for sharing your story with us. I would like to open up to the panel and really in a brief, if you had to look at what your greatest need is and how can folks help who are on this call, and maybe start with Anne and then Morine and then Tony.
Thank you both. I think what my colleagues have shared, Dr. Tonny and Morine, resonate the same for Kenya. And as we say, there is no health system without health workers. So our greatest need is actually ensuring that the health workers we have, especially the midwives and the nurses that support be it immunization or safe delivery, that they have the right skills. They're already trained. We do have some numbers, but from time to time, they need upgrading of these skills to ensure that they are using the right formulations, they're updated in terms of protocols, and they're able to respond to the needs of women as well as children. Then secondly, we do have the issue of some equipment. Government provides this equipment, but it's not always the same, especially in remote areas. For example, there's what we call a fetal Doppler. A fetal Doppler is a simple tool that that the health worker uses just to do fetal track monitoring, to listen to the baby, which is very critical to know how the baby is faring on when it is in the womb. This tool costs around $50 and has really revolutionized where we have used it, especially in remote areas, to ensure that that health workers are supported with the right equipment. Then the last one is about engaging very deeply with communities, supporting community health promoters to be able to share the danger signs with mothers so that they are advised to come to the facility early on and that they're able to refer mothers. Sorry, I have a bit of flu.
Thank you, Anne.
Sorry about that. So those are the three major things I would point out: the upskilling of health workers. Secondly, some small equipment that are very critical for safe delivery, as well as lastly, on the issue of community health promoters to be able to engage at the household level so that mothers are able to recognize danger signs and go to facilities in good time. Thank you, and yeah, apologies, I really do have a flu. Yeah.
Thank you, Anne. Morine, you kind of mentioned the barrier, the travel barrier. How do you address that? Is there a way folks here can help you address that issue? You know, you mentioned motorcycles, but is there a really, how would you address that issue?
Sorry. I'm so sorry about that. I would think the best way to address this is to bring the services close and to the mothers, since the next facility is really far and the roads are really bad. We also have challenges like the project we are running in that facility is ending this October. Since the distance to the next facility is really far, it will be okay to keep this frustrated community smiling with the good services we're offering. Yes, and I would feel good if really the health center is upgraded to the health center 2 is upgraded to health center 3, or if not possible, we are able to conduct emergency deliveries at the facility. That's according to me, and I would really love that all the midwives in remote facilities be mentored. Medicine is dynamic, it keeps changing. It will be okay, really, to mentor the midwives on the new skills so that we say goodbye to maternal death, neonatal death. Thank you so much.
Thanks. Thank you so much, Maureen. Tony, if you could maybe just do a quick wrap up and kind of, because I want to make sure we have enough time for folks to have questions. So very shortly, I'm sure people will have questions. So if you could just do a quick wrap up.
Yeah, sure. I'll not repeat what Anne has said and what Morine has said, because very much challenges that we are having. I'll just point you to what I said earlier as one of my most favorite projects that I implement in Amref Uganda, and that is the fistula repair project. Friends, it costs $154 to repair successfully an obstetric fistula and get that mother out of that misery that she goes through with leakage, uncontrollable leakage of urine. Now that is in a facility that is built like a health center, government, but we come in with the resources, the equipment, and the surgeons that we've trained as Amref to do that. Now, when we take the services closer to the people, like Morine mentioned, that is organizing a camp setting. It will be a little more expensive because we're moving almost everything, including theater, to a new place. And that takes about $380 to repair one in a camp setting or outreach setting. But in a static facility setting, $154 to make a difference in this women. I talked about a backlog of about at least 100,000 fistula cases still out there to be addressed. So the call is any donation, any amount will drastically make a change to serve these people. So it's not that you must give $380. If you can afford $1, $2, it adds up to this figure and will change the lives of these people. Thank you so much. Over to you, Bob.
Thank you, Tony. Emily, would you mind jumping on and help field questions?
Hey, I'm not seeing any, which is also a good thing, I think, sometimes when there's such good information being given. Yeah, I mean, we from the US are, we're just really inspired so much by our colleagues and our friends in the field. It's really amazing the work that you all do under the circumstances that you are. So thank you so much also, again, from our side.
So I think if there are no questions in the chat, you will see if you feel moved to contribute, there are links for the Canadian office, the UK office, and the US office. Bob, I really do appreciate you being here to moderate this call. Maureen and Tony, thank you so much for sharing such personal and very moving stories about how you got into the work that you're doing today and how you're helping so many people in your community. And thank you so much for talking with us about the holistic overview of what Amref does to put that Maureen and Tony's work into perspective. For those of you in the United States, we also have a New York City marathon charity team This year we have 11 fabulous runners. One who actually is working at Amref Kenya. So if you're in the area.
Jenny, I just saw that Fatima's on the call. So Fatima, if you want to maybe say a word about your journey and your marathon, since we have a couple minutes, we'll let you have the floor.
Yeah, thank you. Thank you very much. My name is Fatima Said. I'm a business development manager at Amref Health Africa, based out of Nairobi. I primarily manage or lead the resource mobilization for Amref in Kenya, but I still work with our other offices around in the South, really. So I'm here today. I am not medical doctor, I am not a technical resource, but I am a resource mobilizer. I have been working with the technical teams to mobilize resources for I think about now 8 years in the different fundraising, in the different technical areas that we have. But this year, I am doing it differently. I'm really here I am running the New York Marathon, the whole 42.2 miles in support of the work we do. In support of the work we do, in support of all our maternal health work. And really today, hearing much my colleagues have said, and more so what Morine has said, has really affirmed me. And I'm getting emotional that we are really out here doing the most, as we say in Kenya, really, really fighting for our communities, ensuring that services are taken to the last mile, ensuring that we have really, we are really embracing our spirit of Ubuntu, that we are because they are. And for me, what is great really is that over the past years, I have seen the transition of how we do our programming. And now we have communities at the core. We are designing our programs around the needs of the communities. Like it is very personal. We've heard from Anne, from Tonny, from Morine. It really is personal. We are not, we are asking communities what are their pain points, and we are trying to really to address that. So really, I'm still fundraising for that cause. I'm still working really hard. I am training really hard. I just started tapering, so now I'm going a bit easy. And I'm really looking forward to your support. Please, Jenny, if you can share the link, please donate. It's still supporting the cause. Donate in kind and in cash. You could also share it with your friends and within your network so that we are all working together to really advance this cause. Otherwise, thank you very much for the opportunity and for really this insightful session. Thank you.
Yes, thank you so much, Fatima. We can't wait to cheer you on when you come to New York. To all of our colleagues in Uganda and Kenya and elsewhere, have a wonderful evening. To all of us in the UK, have a wonderful afternoon. And for the US, I hope you have a great day. Thank you all so much for joining. We'll send a recording out to you all soon.